Hey folks, this is Abel James, and thanks so much for joining us on the show. Did you know that doctors were treating diabetic patients with high-fat, low-carb diets all the way back in the 1700s? Until the discovery of insulin in the 1920s, diabetes was largely treated and managed with dietary intervention, using high-fat meats and fibrous veggies, then called the animal diet. Though high-fat ketogenic diets were found to effectively treat diabetes for over a century, they were largely abandoned due to the rapid adoption of insulin in the 1920s, which was considered then to be a miracle cure. Prioritizing drugs over lifestyle with insulin therapy, however, led to unexpected long-term complications in patients, including damage to large and small blood vessels that results in heart disease, strokes, kidney damage, neuropathy, amputations, blindness, dementia, and a decrease in life expectancy. Now, more than a century after the discovery of insulin, despite all advances in modern science and medicine, blood sugar control at the population level is getting worse. Once a rare condition, diabetes is now so common that drugstores dedicate entire aisles to it. 1 in every $4 spent in American healthcare goes to diabetic patients, with over $300 billion in direct costs every year. The diabetes story is a metaphor of the rapid adoption of a wonder drug without knowing the long-term consequences. And in an age when Hollywood, influencers, and the media are touting the seemingly miraculous benefits of our latest weight loss wonder drugs, GLp agonists like Ozempic, it's worth examining the long-term risks and consequences of heavy-handed pharmaceutical interventions. Today, we're back with our friend Gary Taubes. Gary is an investigative science and health journalist and best-selling author of Why We Get Fat and Good Calories, Bad Calories, as well as his new book, Rethinking Diabetes. Gary has received 3 Science and Society Journalism Awards from the U.S. National Association of Science Writers, and is the recipient of a Robert Wood Johnson Foundation Investigator Award in Health Policy Research. Gary has dedicated his work to dismantling conventional nutritional theory with his research, lectures, and books. And at this point, Gary is better versed in diabetes literature than pretty much anyone alive. But before we get to the interview, a very quick but exciting announcement. After speaking with a number of creative friends, mostly writers, podcasters, and musicians, I've decided to launch a brand new Substack channel. I'll be writing about health, performance, and technology, sharing our favorite recipes, and much, much more. You can find me by looking up Abel James in the search bar on Substack, and you can join for free or even support my work directly as a member. So come join the Abel James Substack and leave a quick comment so that we can connect. I always love hearing from you. All right, on to the show with Gary. In this episode, we chat about why lifestyle interventions that effectively treated diabetes for over a century were abandoned by the medical establishment, how flawed dietary guidelines in the 1970s recommended high-carb diets for heart health without evidence, why the modern push for plant-based diets is based on bad science and misconceived journalism, why the wide adoption of diabetes and weight loss wonder drugs like GLp1 agonists should raise long-term safety and side effect concerns, and much, much more. Let's go hang out with Gary. All right, welcome back, folks. I'm honored that returning to the show today is our friend Gary Taubes, an award-winning investigative science and health journalist, speaker, and best-selling author of a number of books, including Good Calories, Bad Calories, The Case for Keto, and his latest, Rethinking Diabetes. Gary studied applied physics at Harvard University, has a master's degree in engineering at Stanford, and in journalism at Columbia University. Gary, it's a pleasure to talk with you again.
It's a pleasure to talk with you, Abel. I'm also always impressed by the idea that somehow my academic credentials from 45 years ago mean anything. It's like, yeah, well, I must have been smart.
You've clearly got a lot of horsepower and a lot of energy to dig into the research. And at this point, you're probably one of the best. I think I heard you on another interview talk about how you might be one of the best versed in diabetes literature than pretty much anyone else alive. And you've dedicated, 25 years to studying the bad science in nutrition?
Yeah. No, I got into it in the late 90s by accident, and I've never been able to get out. So, and it's not so much what you need to do this well is sort of profound curiosity. And so if you're always, it's not so much doggedness or anything. You just want to, it's like you're buying a used car. And you want to know every way that, like, why is this not a mistake? And so you just keep asking questions and asking questions. And in this case, in my work, I end up going back in time. The medical world would say, I'm looking for the evidence base of why we believe what we believe. And when you go looking for it, you often find that it doesn't really exist. And that's sort of the story in rethinking diabetes.
And so you mentioned in the book that this was once a rare condition, but now diabetes is so common that drugstores dedicate entire aisles to it. So maybe we can start with a little bit of the story that people might not be familiar with, all the way back in 1797, when the first diabetes case went into remission.
Right. So this is, and again, this is what I mean about going back in time to the history. So today, maybe 40 million Americans have diabetes. Almost 30 million have been diagnosed, and the other 8, 9, 10 million don't even know they have it yet. 60 years ago, in early 1960s, maybe 1.5 million had it. And then you go back to the late 19th century, and this was a disease so rare that in hospitals, maybe 1 in every 300 patients. Okay, so again, compare that to the present. In hospitals like the VA system, the Veterans Administration, 1 in 4 patients are suffering with diabetes. So this has exploded in modern times. Prevalence is almost unbelievable. And one of the things that keeps striking me as a journalist is why nobody really cares. Why this is just somehow taken as an acceptable number of cases. And you imagine if lung cancer cases had exploded in prevalence by 600% from the early 1960s, or HIV cases, and there would be teams of investigative scientists crawling over every inch of the country to try and figure out what happened. Here it's left to people like me. And one of the things I learned in this I became a medical historian doing my research, and mostly with my book on sugar and then this book. But what you learn is that the first case of diabetes that was ever really successfully treated was 1797. It was a British physician named John Rollo working for the military. His patient was a Colonel Meredith who lost a lot of weight and was hungry all the time and thirsty all the time. And, so he's diagnosed with diabetes, and Meredith decides, because you're diagnosing it by, basically back then they would taste the urine, or they'd have their assistant taste the urine ideally, and if the urine was sweet, that confirmed the diagnosis from these other symptoms, which were the hunger and the thirst and peeing all the time. And Rollo decides that since there's sweet stuff in the urine, that this is a carbohydrate problem, although he doesn't use that word, and he basically prescribes a diet without carbohydrates in it. So he starts off with rancid fatty meat and green vegetables, and Meredith follows his advice, and his diabetes basically goes into remission. He ends up living another 12 years with this disease that was, by the time it was diagnosed, was very, very quickly fatal. Rollo was amazed by this. He writes a memo, a pamphlet that he circulates throughout the United Kingdom, and he asks physicians, hey, look, says basically, I think I've got a cure for this disease. Why don't you try it on your patients? And a few dozen patients, physicians write in with their experiences, and then it's pretty clear that if you don't allow these patients to eat carbohydrate-rich foods, sugar, sweets, starches, breads, that they don't really manifest the symptoms of the disease. So it's like the disease is triggered by eating these foods, and through the 19th century, this becomes what today we would call the standard of care. So every major diabetes physician in the UK and the US and Europe, and again, diabetes is a rare disease. There aren't a lot of these guys, but the ones who are studying and the ones who are making their careers treating it are using what was called the animal diet. It's effectively keto today. And this was very successful with the patients that today we would say have type 2 diabetes, and it could delay the progression of type 1 diabetes, although those patients lack insulin, so that's a fatal disease until insulin is discovered. And insulin is discovered in 1921, and all of this is thrown out. Suddenly you've got this very powerful drug. It's so good at lowering blood sugar that it creates the condition of hypoglycemia, low blood sugar. So now you've got a disease of carbohydrate metabolism, so the patients can't metabolize carbohydrates. You treat it with this incredibly powerful drug, and that drug requires them to eat carbohydrates so that the drug itself doesn't kill them. So in the course of like 2-3 years, you go from telling these patients you can't eat any of these foods to making sure they eat them regularly so that the cure doesn't kill them. And from then on, the 1920s onward, diet becomes kind of an adjunct to drug therapy. So the idea is we're going to pay lip service to diet. We're going to tell the patients what they have to do with their diet, which is with insulin, they have to eat a set amount of carbohydrates at every meal and at snacks, and to make sure they don't have low blood sugar and die from that. And then we're going to give them enough drugs to cover any of the sins that come from this diet. And again, that philosophy basically is what we're living with today, 100 years later. And you ask the question, how successful are we at treating diabetes? And it's very true that patients diagnosed today will have a longer life expectancy than ever before in history. We've got one great new drug after another. The latest are these, the Ozempic, Wegovy type GLp1 agonists. And yet, the average patient with type 2 diabetes spends about $16,000 a year on medical care. I mean, twice that of a healthy patient. There's still all the diabetic complications that we've known about for hundreds of years. Well, let's say 100 years. Heart disease, stroke, atherosclerosis, nerve damage. They're all common disorders. People who are very compliant, very intelligent patients who use their drugs just as they're supposed to still end up having lower limb amputations and going blind. And the expectation is, let's get more drugs. We will always have a drug for the side effects. And the rethinking part is nowhere in the last 120 years has anyone in the diabetes community said, the conventional sort of the diabetes establishment said, hey, wait a minute, maybe we should think about making diet the first approach and minimizing drug use instead of giving lip service to diet and maximizing drug use. So that's the 225-year story in a nutshell.
So essentially, they had it figured out from a lifestyle and diet perspective for 100 years plus. And then once you discover and isolate insulin, it becomes a drug. It's something that then you need to manage this drug through diet. And that becomes the recommendation, to eat enough of these carbs that you can't metabolize without the drug to make sure that you don't go hypoglycemic. Is that essentially right?
Yeah. And the other thing that happens is, because this drug is so powerful, well, first of all, the physicians think of all diabetes as basically an insulin deficiency disease. And much of my book, when we were off, before we started recording, you mentioned it's a tome. It is a tome. It's a history of medicine and history of medical science, and a book about sort of how doctors think. and how scientists think and the difference between them and the problems, why medicine was always considered an art rather than a science, and why maybe it should still be considered more art than science. Much of our philosophy about treating this disease begins with the discovery of insulin and is locked in by within 15 years of insulin's discovery. They know virtually nothing about the disease. This is a disease of high blood sugar in response to what we're eating, but they can't measure blood sugar. In type 2 diabetes, it's a disease which is 90 to 95% of the cases, it's a disease of insulin resistance, not insulin deficiency. But they can't measure insulin levels. So in type 2 diabetics have high insulin, not low insulin, at least until the disease is in its late stages, but they can't measure insulin until the 1960s. Nobody ever bothers to measure how patients' blood sugar responds to the foods they eat until roughly 1970, and then it's one individual, one patient who catalyzes a revolution, and they don't do it because they can't do it. It's like the patient comes into the doctor, they take a blood test. Well, they check the urine, which they could do in the doctor's office, and they check a blood test and send it out to a laboratory. And 2 weeks later, they tell the patient, when you came into the doctor's office, you had high blood sugar instead of high urine sugar. Their treatment is to get the sugar out of the urine. Okay, so you're dosing your drug to get your urine sugar-free. This is until the 1970s, so for 50 years. But the sugar in the urine represents sort of your blood sugar levels 6 hours earlier. So they cannot really control any of the variations in blood sugar. So they consider treatment a success if the urinary blood sugar, if there's no longer any measurable sugar in the urine. And through all of this, the assumption is patients don't want to be on a diet, particularly young kids, right? Because the kids, if they're diagnosed with type 1 diabetes, which is a form that kids used to get before type 2 diabetes became a disorder of childhood as well, it's a pretty terrible disease. So you don't want to tell the kid that, look, you've got this disease that's likely to kill you within a year or two, and by the way, you really shouldn't eat a piece of bread or have ice cream, because that'll accelerate things. So the idea is let the kids eat what they want, give them insulin. And if they need more insulin, we'll give them more insulin. And it seems like a very reasonable thing to do. And so by the 1930s, this idea is like, you just eat the liberal diet, eat as many carbs as you want, we'll give you insulin to cover it and you'll be fine. And as they're telling patients that, they're also realizing that the patients aren't fine, that there's this tidal wave of complications that's killing them. But nobody says maybe it's killing them because we've approached this all wrong. We've sort of thrown out the idea of not eating carbs because you can't metabolize them. It's just, the history is wild. I had a blast writing this book. I mean, it was a revelation. It's not the easiest book to read, I'll admit that, but it was a fun book to write. And, I'm still hoping that it will ultimately just change the dialogue on this disease, that the establishment will say, there's a point here that this disease doesn't have to be a chronic progressive disease. It doesn't have to, patients don't have to be on 3 drugs for their blood sugar and drugs for their insulin, their blood pressure, and then drugs for, getting injections in their eyes to control their retinopathy, their eye damage. I mean, this is all a side effect of apparently a side effect of the way we treat this disease, compared to how we could have.
So previous to that, going back, a few hundred years, talking about the animal diet, it's so fascinating because you were encouraged to eat fatty meat and veggies that were boiled 3 times to reduce the amount of digestible carbs. And this was used therapeutically for many, many years. And then all of a sudden, you kind of have this miracle cure that appears in the 20s and then into the 30s, and it seems like it's working well because blood sugar seems to be being managed, except the longer term damage starts appearing 5 or 10 years later, which is, in large part invisible short term, but actually starts to shorten the lifespans and the quality of life of anyone who is almost, I don't want to say abusing insulin, but that's kind of what it turns into, doesn't it?
That's very much what it turns into. But they're not abusing insulin because they're using the insulin following their doctor's orders.
Sure.
So it's the doctors, in a sense, who are abusing insulin, but it's just, you don't see what's going to happen 5, 10 years down the road, 15 years down the road. So they're making these decisions with no knowledge of the long-term effects. Like today, ideally, you would do some clinical trials comparing different approaches to insulin therapy, with a high-carb diet, with a low-carb diet. I mean, again, this is wishful thinking. And then you'd do it on, say, 500 patients in each arm, and you'd run it out for 5 or 10 years. So at least might get the first inkling of how the chronic complications or consequences of this disease and insulin therapy play out. But they didn't have that. The idea of a randomized controlled trial didn't set in until the late 1940s. So instead, by the time they start seeing these complications, they really have no idea why they're seeing them. They assume it's because of bad blood sugar control or bad urine, that the patients with more complications are the patients who do a poor job of controlling their blood sugar swings. But they assume that that's about how they're using the drugs, not how they're using the diet. And again, they never think back, even though one of the horrible coincidences in this business is in 1921 through 23, 2 physicians at the University of Michigan actually test a very high-fat ketogenic diet for diabetes. And they report that the patients do remarkably well. I mean, they just, as long as they're eating it, they do remarkably well. And a Swedish physician, a guy named Petrin, actually used a diet that's like 95% fat for patients with type 1 diabetes. It's funny because the German clinicians who were the best in the world at the time, this is a period in time in which the lingua franca of medicine was German. The German physicians said they wouldn't want to live without Petrin's approach, even though one of the problems was, like, he would feed patients basically cucumbers with butter on top. He wouldn't even let them eat bacon because there was too much protein in the bacon, and 60% of the amino acids in protein convert to glucose, and then you have to have insulin to deal with that glucose. So just at the beginning of the insulin era, there was this window opened into the power of these very high-fat, very low-carbohydrate diets, and it closes almost immediately because insulin seems to be so effective. And like I said, the problem, one of the arguments against a book like this is, look, aren't we doing much, much better controlling this disease than we ever have? And the answer is yes. But it's still considered a chronic progressive disease. It'll get worse. It still costs an enormous amount. The burden financially on the patient and the burden psychologically on the patients to live with these diseases, the multiple drugs, the side effects to the multiple drugs. It is conceivable that this disease does not have to be either chronic, well, certainly not progressive, that it could be reversed. And beginning around 2000, clinicians finally started doing the studies to show that that's possible. Type 2 diabetes, not type 1, but type 2. And, this is a disease that can be kept in remission by diet. It's that simple. Maybe not for everyone. We don't know that because we've never done the clinical trials, but it can be kept in remission. By that, it means no drug therapy, no insulin therapy, no weight gain, none of these complications and consequences, no blindness, no nerve damage. Don't eat carbs. Replace those calories with mostly fat. and you thrive because it's the carbohydrates that your body can't metabolize properly.
I was struck by the explanation of the old-fashioned high-fat diet, because a lot of people think about ketosis, keto, especially in the past few years, as some newfangled fad. But so for Elliot John wrote or said, patients were always urged to take more fat. At one time, my patients put fat in their soup, their coffee, and matched their eggs with portions of fat of equal size. The carbohydrate were kept extraordinarily low. I've never had butter and eggs quite like that. That one struck me the most when I read it.
Well, again, he's talking. So, this is Elliot Joslin, who was the leading diabetes. He opened the first dedicated diabetes clinic in the U.S. in Boston. He was a Harvard-trained physician, whatever that was worth, in the late 19th century. And he opened a diabetes clinic. So he dedicated his clinic to diabetes. So he saw more patients than anyone else. So by 1917, when he wrote the first edition of his textbook, it was based on his experience from 1,000 patients, when no other physician in the United States might have seen more than, say, 30. So Joslin was considered the god of diabetes. And the issue is, back then, so type 2 diabetes is a common form of the disease. It's more likely to get it as we get older, as we get heavier. It associates with obesity. It's a disease, I said, of insulin resistance, so your body doesn't respond properly to the insulin your pancreas is secreting, so your pancreas keeps upping the amount that's kicking out, trying to lower blood sugar, and in the process of doing that, you get fatter and fatter, and this sort of metabolic hell proceeds. Type 1 diabetes is a disorder of sort of pancreatic insulin deficiency disorder. So your pancreas is failing to produce enough insulin and eventually failing to produce effectively any. So both of them have high blood sugar, but one's a low insulin disorder and one's a high insulin disorder. In that era, by the time the patient showed up in the hospital, they're not going to the doctor every year and getting a blood test and, blood sugar measured or a hemoglobin A1C or any of the things we do today in physicals. They show up at the physicians at the clinic in the hospital when this disease is in the end state. So now, if they were overweight to begin with, they've lost a lot of weight, they're hungry all the time, they're thirsty all the time, they're peeing all the time, they're weak and emaciated, and it looks a lot like type 1 diabetes. So Joslin, whether they're treating these young kids with type 1 or as Joslin's mother had diabetes. That's one of the reasons he was interested in an older woman in her 60s who's lost a lot of weight. It looks like the same disease on some level. And so the treatment is this severe high-fat diet because it's been caught so late in type 2 that it looks like type 1, and then it's really in the late stage. It's unclear whether these people can ever really kick up, go back to a healthy level of insulin secretion and insulin sensitivity. So you have massive amounts of fat. You wanted to give them as many calories as you could, or the doctors did, because they show up in the clinic, in the hospital, emaciated. They've lost all this weight. You want to put weight back on them. That seemed like a natural approach. You knew you couldn't feed them carbs because that was the problem, so you fed them fat instead. And like I said, if you're in Sweden and Petrin, a lot of fat, mostly fat. When these guys at the University of Michigan, Newberg and Marsh, first pushed their very low-carb, high-fat diet, the point that they made is you had to keep protein low there too, because you didn't want to try and force the body to deal with the glucose that would be converted from the protein. So the way to do that, the highest fat as possible. That was interesting because, before I'd always written about obesity and its relationship to heart disease, but I'd never really delved into diabetes. And it's kind of the idea that this diet was so common, this way of eating was so well accepted as a treatment was effectively stunning to me. I had no idea when I started this research.
And maybe you could talk a little bit about what exactly drives insulin resistance. So what is at the root of this metabolic dysfunction that so many people are now facing that they weren't really wrestling with before?
Well, that depends on who you talk to.
Sure.
Okay.
It's a can of worms.
It is a can of worms. So my sort of null hypothesis, when I was doing good calories, bad calories, I was interviewing some of the biochemists. These people were still alive who had done seminal work in the 1960s and 70s. And their belief was that insulin resistance started in the liver. So type 2 diabetes, and it's a point I make in the book because this research goes back, to the 40s or even the 20s, 1940s, that insulin resistance starts in the liver, and it starts basically with the accumulation of fats, and it just so happens that sugar, which coincides with the explosion of diabetes around the world, these diabetes epidemics, the sugar is a glucose molecule bonded to a fructose molecule, and the fructose is metabolized in the liver. And when you're eating sugar and particularly drinking sugary beverages, your liver is getting a level of fructose, the likes of which it never evolved to see. And the biochemistry says this sugar is converted into fat. Fructose is the carbohydrate that's most easily converted into fat. And you've got fat accumulation in liver cells being blamed on sort of starting insulin resistance in the liver, and then that localized insulin resistance spreading. So my belief is sugar and sugary beverages are probably the very likely cause. There are other people now arguing for seed oils, a hypothesis I don't find compelling, but the counter-argument would be, of course, I don't find it compelling. If it's true, I missed it in my books. So, but many people are clearly also born insulin resistant. There's a concept called fetal programming, where you can, in effect, inherit it from your mother in the womb, and then it's going to depend on what your mother ate, when she was pregnant, and how your mother's sort of metabolic health when she became pregnant. So if she was overweight or obese, or had type 2 diabetes, or even became gestationally diabetic during pregnancy, or gained a lot of weight during pregnancy, then she will pass this on to the infant, to the child, and that child will grow up with a tendency to be insulin resistant in response to the carbohydrate-rich environment. Oddly enough, I don't get into this cause so much in this book, because this book is more about therapy and the thinking about therapy.
Okay, so let's go back to 1971 when the American Diabetes Association put out a public health nutritional guideline to patients. And they basically say patients with diabetes should get over 50% of their calories from the one macronutrient that they can't metabolize without pharmaceutical help, namely carbs and sugars. let's talk about that a little bit, because that seems a little bit strange that was the recommendation then, and then it's continued to kind of be as such ever since, with almost no questioning.
Yeah, they've told, well, this is what, again, I keep wanting to think I'm doing these people a disservice. And I'm sure the diabetes community, if they get motivated to read the book, will say, you are doing these people a disservice, you're biased, you're not appropriately reporting what really happened. But this really did happen. So, and it's one reason in all of my books, I end up talking about the history of this belief system that dietary fat causes heart disease. One thing I didn't know was in the diabetes world, that dates back to the 1910s. And by the 1920s, his fellow Elliot Jocelyn had decided dietary fat caused heart disease. And then he kind of flip-flopped when there was evidence that this high-fat diet, reversed one of the symptoms of incipient heart disease, which was very high triglyceride levels, high blood fats. And then he kind of fell back into his knee-jerk beliefs, and that fueled this anxiety about using high-fat diets in the diabetes world. But patients with diabetes are at very high risk of having heart disease. This disease accelerates atherosclerosis and arteriosclerosis, which are sclerotic plaques throughout your body, not just the coronary arteries. So in the 1950s, this guy Ansel Keys, this University of Minnesota nutritionist, gets this idea that saturated fat, dietary fat, causes heart disease, and then it's saturated fat causes heart disease, which is kind of seen as animal fat causes heart disease. And by the 1970s, the idea is it's in the late 1960s, it's saturated fat raising LDL cholesterol. And this is kind of the simplest possible hypothesis. Simple in the sense that you could measure cholesterol. So the doctors could measure cholesterol, so they latched on to, and there was cholesterol in the arteries and the walls of the plaques, so they latched on to this idea that cholesterol was causal because it was the only thing they could measure. By the 1950s, people are writing articles saying, look, you can measure 50 different things in the blood. I mean, our blood is this incredibly rich, biological fluid. I mean, it's full of things that could cause heart disease. Why are we focusing just on cholesterol? And the answer is, well, because we could measure cholesterol. So through the 1960s, and this is a story I first wrote up in Good Calories, Bad Calories, and then I have to figure out a kind of different way to write it for each subsequent book because it's so relevant. The research community does a series of clinical trials to test this hypothesis. The trials fail to confirm it. So they don't actually show that people who eat low-fat diets live a day longer than people who eat high-fat diets, and in some cases, the people who eat low-fat diets seem to die more often than the people who eat high-fat diets. But by this point, these trials are so expensive that the idea is just doing the trial begins to confirm to people that the hypothesis must be true. It's the exact opposite of what you're supposed to do in science. And by the early 1970s, the American Heart Association, late 1960s, is basically telling every American old enough to walk, literally over the age of 2, including pregnant women who have never been studied, none of the trials even included women, that they should go on this low-fat diet, and that's what's going to prevent heart disease. And so the American Diabetes Association just thinks, well, the American Heart Association knows what they're doing. And not the ADA. I mean, the ADA puts together a committee of nutrition experts. The committee is basically dominated by the chairman, so he writes the article and then gets everyone else to sign off on it. So you say the ADA, but again, this was another sort of revelation in doing the research. What you mean is this one committee, and then what you really mean is the 1 or 2 dominant physicians in that committee. In this case, it was a University of Washington guy named Ed Bierman. And they just decide, in effect, that the American Heart Association's right, that the diabetic patients are at such high risk of heart disease that they should tell them to eat low-fat diets, and a low-fat diet is a high-carb diet. So now you're telling patients who can't metabolize carbohydrates safely that they should get more than half of their calories from carbohydrates. And I mean, there's some wishy-washy belief that maybe they won't need more drugs if they get more carbs. And there's a New York Times article that talks about this that says, this is a paradigm shift by the ADA. They're now saying that carbohydrates are not a problem in diabetes. That was our mistake. It's the fat after all. It's a little crazy. I mean, if somebody had said back then, even to Ed Bierman, wait a minute, you're suggesting that I should get 50 to 60% of my calories from the one carbohydrate that I can't metabolize, the one macronutrient I can't metabolize safely, so you're condemning me to a life of drug therapy to control the symptoms of the diabetes because you think you're going to slow down my heart disease by getting me not to eat fat. Are you out of your mind? Actually, the way this was described to me best, at one point I had this conversation as an epigraph, a quote in the very beginning of the book, but it sort of gave the whole book away, and I didn't want to do that quickly. So it's in the epilogue. But I was interviewing a guy, a former chef, who became a journalist, who was diagnosed with type 1 diabetes in 2016. And when you're diagnosed with type 1, he was in his 30s already, and it's a shock. I mean, and you go from somebody who has never really thought about this disease, unless you've got a family member, a friend who has it, to being immersed in diabetes land up to your eyeballs. Now you have to learn everything you can as quickly as you can. And meanwhile, your physician or your endocrinologist or your diabetes educator is telling you what you now have to do. And the physician says to this guy, so what you're going to do, you have this disorder where you can no longer metabolize carbohydrates safely. So we're going to give you insulin for the disorder, and then you're going to eat 40, 50, 60% of your calories from carbs to make sure to keep the insulin from causing hypoglycemia. And he says, wait a minute. What you're telling me is that carbohydrates are now toxic to me now. And insulin is the antidote. And I should eat the toxin and take the antidote? Why don't I just not eat the toxin? And he says his doctor looked at him like nobody had ever said that to him before. Like he'd never crossed his mind. And the idea is because if you don't eat the carbs, you got to replace those calories with fat. The easiest way to do that is with animal products, because animals tend to be fat and protein. They're not a large carbohydrate content in us or any animals. So, and when you're eating the fat and it comes from animal products, it tends to be saturated fat, or a significant portion is actually most is monounsaturated, but that's a different story. Anyway, so these doctors have been trained to think that a diet without carbs is going to kill people because it's high in fat and high in saturated fat. So you're back to this hypothesis that was never confirmed, that fat causes heart disease. And it's still out there today. I mean, very, very smart physicians who I recommend, who have very successful podcasts, will still tell you that your primary goal should be to keep your LDL cholesterol low by diet, because, well, we have drugs that seem to work for some people, depending on who you talk to. So, yeah, that's what we've been living with.
Yeah, this one sentence. So essentially, high carb diets would be prescribed to allow for the drugs to be used freely, not to minimize their use. I think that sums it up pretty well. It seems like the tail wagging the dog a little bit.
It does, but this is what the assumption always was, and you hear this all the time, patients don't want to be on diets. The one thing we know for sure is people don't follow diets. Which could be true. The problem is that the diets that have been prescribed for heart disease, for weight loss, have been the wrong diets. They don't really work. Well, then one for heart disease, who knows? Because you can't, if you're preventing heart disease, you can't see the disease being prevented. So you have no feedback that it's actually doing what is proposed. And meanwhile, these are diets that, if people like you and I are right, they're going to make people fatter and drive them towards diabetes. So we've been putting people on diets that don't work, and then saying they don't want to stay on diets, and assuming that's true of all diets. And the arguments that we've been making is that get people on the right diet, and then they'll comply to the diet, because they're not complying to a way of eating, they're complying to a way of staying healthy. So if you actually say to people, and this is kind of what I'm recommending at the end of the book, but I don't phrase it so bluntly. What I want is doctors to understand what we understand. Right or wrong, I want them to go down the rabbit hole and learn about this approach, which clearly works. Like I said, maybe it works for reasons other than we say it does, but it clearly works. So you have two options. We can put you on these drugs. We could start you off on metformin, although if your hemoglobin A1C is high, we're going to start you on insulin, this very powerful drug. And then we're going to, as your blood sugar deteriorates, which we know it will, we're going to add drugs, and we're going to up doses. We're going to add more drugs, and we're going to up doses, and this is your future. Or we could put you on, get you to eat this diet, which is, there's nothing magical about it. You're just not going to eat these foods because you can't, they're no longer safe for you. And if you do that, far as we can tell, you're good. Again, type 2 diabetes, not type 1. Type 1 is a little more complicated, but type 2, you're good. We don't have to put you on the metformin, although it's probably benign. We don't have to put you, your blood pressure won't go up, so we could leave that out. We could leave out the multiple blood sugar lowering drugs. We'll argue about statins for the next 50 years, but you probably don't need those either. And instead of taking 5-6 drugs a day and spending $16,000 a year on therapy, you will, to all intents and purposes, be healthy. So if they explain that, I think there are a significant number of people who would say, let me try the diet, doctor. I think that sounds like a better idea. But it's not how they think about it. If they did think about it like that, I wouldn't have had to write the book. So.
Yeah. So you also mentioned that basically the diabetes story is a metaphor of the rapid adoption of a wonder drug without knowing the long-term consequences. So we've got a problem and everyone thinks that drugs will fix it. Now we have GLp1 agonists entering the chat room. And that's something that now needs to be addressed as well, because it's really, I can't believe how popular it is amongst people who are struggling with obesity, pre-diabetes, or even people just looking to be young and fit in their 20s or 30s, just kind of taking some of these drugs and peptides like Tic Tacs. So what's your take on all of that?
I mean, that's pretty much it. I mean, I understand people have been struggling with their weight their whole lives. I've been reading, for my next book, I've been reading a lot of the fat acceptance literature. The latest was a book called Unshrinking by a philosopher at Cornell. And they are always pretty much the same story. But the one thing they always say is, I tried every diet. Sometimes they list it. I did paleo, I did Atkins, I did keto, and they never worked. And maybe it's true they never worked. Often when you question people about it, which I've done, they'll say, well, yeah, I lost 60 pounds, but then I stopped and the weight came back. So the diet worked. It was the understanding that carbohydrates are fattening to these people, and so you just can't eat them. If you ever eat them, they will always be fattening. If it's true, though, and it probably is for a lot of people, that, and I don't know what percentage, that no diet works, then these drugs are the only alternative. If the diet works, then it becomes a situation similar to diabetes. Now we have a disorder or a condition or a physical state that can be put into remission by a healthy change in diet. In this book on shrinking, I mean, this woman, Kate Manning, seemed to think that there was no reason why she shouldn't be able to eat, cheese danishes or pizza like everyone else. And I mean, I suppose that's true of me as well. I don't think of it like that. I just don't eat those foods because I know if I do, I'll put on 30 pounds again. So it's sort of, if there's a dietary approach that works, then the question is, what's going to happen 10, 20, 30, 40 years down the line? Especially, so the older you are, that you can guess the more benign these drugs will be, because you'll be on them for a shorter period of time. You're not going to do something like get pregnant on them if you're in your 60s. But as you get younger, then the period of time you're going to be on these drugs is going to be longer. And the question of long-term side effects will always be out there, long-term complications. Like I said, with diabetes, what makes it an interesting possible parallel is that by the time they started seeing this tidal wave of complications, they couldn't identify it as being due to possibly the drug also, because they had nothing to compare it with. And I think we'll have a similar situation here. So if you find out 15, 20 years from now that there are odd complications, and they could be cognitive, for instance, our brains are 70% fat. I'm not sure I want to, and people keep saying these drugs work in the brain. I don't actually believe that's their primary mode, but if they do, I would be very worried what they're doing to the fats in the brain. Or if, it's maybe that's naive, but I would worry about it. So you just don't know what's going to happen. And if these people if they find after a while that maybe nausea increases over time or diarrhea increases over time and they can't tolerate this drug, and they have to go off, what happens? We know what happens after 2-3 years or 1 year if you go off the drug, which is you gain the weight back, but what happens, most of the weight, but what happens if you go off after 10 or 20 years? And the pharmaceutical world is full of examples of drugs that are surprisingly, tragically difficult to get off, even though we don't think of them as addictive. Benzodiazepines most famously. So you're sort of opening up this. The way I hope to describe it in an essay I'm writing is, the famous line by Rumsfeld, there's known unknowns and unknown unknowns. And the medical community tries to deal with the known unknowns. I mean, they know their drugs are being prescribed by the millions now, and that if bad things happen, they're going to have to deal with it. I worry about the unknown unknowns. Like, what is it? 20 years from now, somebody tries to get off this drug. If they succeed, what happens? If they fail, what happens? And the assumption is, well, we'll have new drugs by then. That's always the assumption. They probably will. Hey, they've got AI to help them generate them now. And maybe so I feel a bit like a Luddite, like someone who's not willing to accept the new technology. But when I read there's a wonderful sort of academic history of the early decades of insulin therapy at Elliot Jocelyn's clinic, a book called Bittersweet, written by a pediatrician, medical ethicist, medical historian at Penn named Chris Feutner. And when you start reading about what happens to these kids 10, 15 years down the line and how they seem to be thriving, and then suddenly their bodies just, non-technical term, crap out. They go blind, they get kidney failure, they die, they have heart attacks. And again, 2 years earlier, they would have seemed to have been thriving. And that made me worried about a lot of any medicine, any pharmaceutical that's as powerful as these drugs clearly are.
What about in the few minutes we have left? You talk about, I guess, the hesitance for a lot of the mainstream news sources to really even entertain some of this message, especially around the eating of red meat versus going vegan for the planet's sake or for the sake of health. It seems like it's kind of hard to get in certain places where that conversation used to happen, like the New York Times, for example.
It is. The world has become ever more polarized. And some of my friends put it down to Trump derangement syndrome. So the liberal media, beginning in 2016, suddenly decided that anything Trump believed must be wrong, and decided that, and I'm a member of that liberal media, I mean, that's where all my proclivities lie, that climate change is not just a threat to societies or our health, but a catastrophe in the making. They use terms like catastrophe. I mean, they'll write articles about how kids are getting depressed about climate change, and then they'll scare the shit out of them the next day with these assumptions about how bad it's going to get. Maybe they're right, but I tend to doubt it. But again, that might be wishful thinking. So anything that's associated with climate change, for instance, or industrial livestock in general, is perceived to be bad. The ethical arguments made that used to be on the fringe of the vegan and animal rights activists have been becoming more and more inculcated into liberal values. The idea that you should eat a plant-based diet has always been considered sort of the one universal point of consensus in the nutrition community, even though that's based on very bad science. So you have all these forces coming together to basically argue that we should eat a plant-based diet, even if you have type 2 diabetes or your child has type 1 diabetes. You should feed them a diet. So plants they store their energy in carbohydrates. Like I said, mammals store them in fat, mostly, and some protein. So we keep getting pushed to these carb-rich diets and these sort of belief systems that have been around for 50, 60, 70 years. For a while, people like me made good progress in convincing, in sort of getting our counter-arguments noticed. But what happens is we even sort of age out of the field. The editors that published us age out as you get older, and it becomes an old story. There's Taubes again talking about the evils of carbohydrates. Didn't we discuss that 20 years ago? Yeah, but it's diabetes now. But it's carbs, We've been there. But the problem is if it's right.
Yeah.
So bad science tends to kind of build on itself and spread virally through the community, and bad sort of misconceived journalism does as well. The flip side, the good news is that this kind of called dietary therapy or keto therapy or just carb restriction therapy works remarkably well for people. So even while I can be pessimistic about whether or not the media will ever report on it accurately, whether or not it'll be conventional wisdom in the medical community, people try it. It's all out there. We've gazillion books. All you have to do is Google effective diets or pick your, and at some point people will, if we're right, nothing else really works. So at some point people try keto. Even the ones who go on GLp1 agonists, who right now are like delighted with Ozempic, at some point they're going to think, maybe I should get off that. How should I eat? And a little Googling will get them to keto, and they might say, well, now that I've lost my food cravings, maybe I can live on this meat and green vegetable thing. And they'll try it, and it will work. So it's sort of, on one hand, it's hard to get the message across through the media, and harder now than it ever was. But on the other hand, more and more physicians convert to using this. And even the major health organizations, the ADA and the American Heart Association, much as I like to rail on them, are slowly acknowledging that this is a dietary therapy that not only works, but seems to have works for weight, excess weight and diabetes, seems to have remarkable effects on a whole slew of conditions. So with each passing year, so far their guidelines have been getting a little more liberal. They doubt they'll ever go as far as I would like, but they're getting closer.
Thank goodness for that. We'll keep fighting the good fight. Gary, what is the best place for people to find Rethinking Diabetes? And I was also very excited to see that you're writing on Substack as well with Nina. So you can talk about that as well.
Yeah, so Rethinking Diabetes in your local bookstore, it's Amazon, online. The Substack is exciting. So I joined up. Nina Teichholz had started a Substack called Unsettled Science, and then we decided we would collaborate on it. So it's unsettled.substack.com. We've been focusing on it, so we're forcing ourselves to produce and to make sure our standards are as high as effectively any magazine would be. So we tend to edit each other, which can get testy on occasions. I mean, we do edit each other, but it's like, come on, was it really that bad?
Yes.
The answer is often, well, let's just say it wasn't that good, and now fix it. And anyway, it's a delight. And we're trying to make it a unique source for sort of critical reporting on all these issues of nutrition and health, because so much of what shows up in the media is crap. The let's report this study happened yesterday. We're going to report on what they said as though it's somehow meaningful because it was published or peer reviewed. And so we're covering those kinds of issues and then addressing the bigger issues in these science. So the issues that I care about, for instance, about what makes good science and bad science and why medical science and nutrition in particular is so substandard. I don't know, that's a euphemism. So unsettled-science.substack.com.
Awesome. Well, Gary, thank you so much for coming on the show. It's always a pleasure to chat with you.
Okay, well, thank you for having me.